So this is now flexion and internal rotation. And he can internally rotate in 90 degrees of flexion up to about 70 or 80 degrees. And it's bilateral, so it's a bilateral excessive internal rotation that he has. He has known that already for years and already since his childhood, but never really recognized that it's really more excessive than with the other kids in school. This is now prone position, and we do the internal rotation again in prone position, which means in full extension of the hip. So this is the hip that actually hurts, and we have also here an excessive internal rotation. We have on the healthy side almost no external rotation, maybe 10 degrees. And this is the painful side, and also here he can go maybe till 10-15 degrees of external rotation, which is extremely low. So typically you can go up to maybe 40-45 degrees of external rotation. This is what we call the posterior impingement test, which is also in full extension, some kind of abduction or adduction, and then external rotation. And you can see if you perform this maneuver here that the pelvis actually moves with the leg, so there must be some kind of hard stop, some kind of bony problem, which impedes the patient of doing some kind of external rotation. And here you can see the patient is basically unable to go into the tailor seat, which was not a problem for him until now. Here you can see if you go for external rotation and extension, how the pelvis moves with this provocation maneuver. This was also painful from him, and if we did that, he said he had pain in the buttock and also in the groin, so in the posterior area and also in the anterior area. He has a flexion of maybe 100 degrees, which is normal. It's important if you do really examine the femoroacetabular flexion that you fix the pelvis or you have a hand on your pelvis and you know when the pelvis is starting to move. So this is really the only femoroacetabular impingement motion that you would like to check, and not some kind of lumbar compensatory motion that you would like to check with. This is the anterior impingement test. We always start inferiorly and then we go along the acetabular rim with this kind of impingement test. And this was painful to him. So he has pain in the groin, and if you force it a little bit, then it's really painful for him. So a positive anterior impingement test on the left side. This is a kind of Faber test, so flexion, abduction, external rotation. And again, this was painful for him. There is almost no external rotation, and with this maneuver he would describe pain in the groin. That's how he walks. So he walks relatively normal. There is not a lot of in or excessive in or out towing, despite his big internal rotation that he has. His leg axis is more or less straight. And also this motion in regarding gait is relatively normal, so there was nothing that we really think of that could be pathologic. Again, he was never aware of any hip pain or any hip problems before during his entire life. So these are his MRIs. We have a coronary, sagittal, and axial cut. What you can see is this zone in the medial portion, which looks necrotic here, or at least traumatized. This MRI was taken maybe 2 or 3 months after the injury. This zone is located in the superior portion and in the posterior portion. We have some kind of cartilage delamination, some osseous fragments here, and some kind of underlying necrotic area here. And if you print it in a 3-dimensional CT scan, you can see that this area is in the posterior superior part, in the medial posterior superior part of the femoral head. Here are some radial MRIs where you can show or can see this anterior asphericity, which is relatively marked with him here, kind of edge that is formed here. We have a labral lesion that is seen here, so there's a labral alteration. There is contrast agent running into the labrum. And we have this, what we call decentration. So there's contrast agent in the posterior inferior part of the joint, and it looks like this patient has a part of migration to the anterior superior area of his joint. We also did a degenerate analysis and the mapping of this patient, and we will see whether this really corresponds to the actual damage that we see during surgery. So again, blue is the good cartilage, red would be the bad cartilage. This zone typically here has a lower T1 value, so that is something that we typically see. But what you can see is we have here in the anterior superior portion an alteration of the signal, at least what we can detect with the degenerate, and also in the anterior portion of his femoral head there is an alteration of his signal. While the posterior superior aspect here looks more or less normal, and also the posterior aspect here looks normal. This is part of his CT scan where you can see these free fragments here where the ligament is. There are some kind of maybe fixed fragments here that are still within the cartilage or underneath the cartilage layer, and we measured the femoral torsion, and the femoral torsion with this patient was surprisingly, or not surprisingly, 60 degrees. This is part of our three-dimensional simulation. You would look from the top, so this is when the patient walks. You can see how this excessive torsion leads to a very narrow area posterior inferiorly and potentially impingement posteriorly. This is the Faber test, which means flexion, abduction, and external rotation, and there is a very, very prominent impingement between the greater trochanteric area here and also part of the neck and the ischium and part of the rim. So this is the impingement zone for the Faber test. And when we switch over to the pelvis, you can see that the impingement zone is located on the ischium here, and also some impingement on the acetabular rim posterior inferiorly. So what we think, what it is, and this is not him. This is the ligament, which is under tension. If you do external rotation and extension, exactly what he had during his injury, and we think that he has at least either a partial tear of his ligament or a full tear of his ligament with kind of avulsion fracture on the femoral side. So that is our diagnosis. We think it's a partial or full avulsion fracture of the round ligament due to his excessive femoral antetorsion. And we think he has a focal posterior superior necrotic zone of the femoral head. And the pathomechanism, we think, is a posterior, mainly extraarticular impingement with a traumatic subluxation of the femoral head. And the aim of the surgical treatment is, of course, we would like to remove those loose bodies. We would like to reduce the excessive torsion. We would like to treat the posterior inferior impingement. And we would like to rotate this damaged zone, posterior superiorly, out of the main weight-bearing zone. We would like to potentially treat the cartilage defects, if we can, or if there are any, refix the labrum or treat the labral tear, and we would like to do that with a minimal change of leg length. This is the aim of the surgical treatment. On the left side, you can see the different slides that are explaining a little bit in more detail what we are going to do. So it's a stepwise description of our surgical approach. We will tell you during surgery exactly what we are going to do, what kind of operation it is. It's a surgical hip dislocation, as we have mentioned, and there will be some kind of additional procedures that we are doing, or Klaus Siebenrock is doing. If you have any questions during surgery, just let us know and we can discuss it right away. And you can also ask Klaus if there are any questions. Again, the case here is online. If you go to Program Live Surgery, you can check the radiographs of the patients once again and make your own opinion what you would like to do. Okay, maybe we can switch back to the OR and see how far Klaus now has gone.